We're going to go ahead and get started. My name is Jamie Stutz. I'm a co-leader of the Cancer Prevention and Control Program, and very excited that everyone's here today for the presentation. I have just a couple of announcements first that the Cancer Prevention Control Program also has our own seminar series tomorrow at noon. We have a very exciting speaker, Dr. Lauren Zamaro, who will be talking about mindfulness-based interventions to support quality of life and well-being. So if you haven't gotten a notice of that, please let me know and I will get that to you. And then additionally, I wanted to let you know about the Cancer Prevention Control Program retreat that's going to be held on Friday. If you haven't signed up or booked for that and you are interested, please do that as well. So I'm very excited to share with you an introduction for Dr. Shobha Srinivasan. Shobha is someone who has been on the leading edge of addressing health equity, supporting health equity, addressing, identifying, and working to mitigate health inequities at the NCI for quite some time. She started her training in India with a master's, which I didn't know this, Shobha, in economics, with an undergraduate degree, and then her master's in sociology at Kerala University, and then finished her PhD at Loyola in Chicago before taking some jobs and working on some biostatistics, but also always having that integrated piece around health equity. Before a lot of the rest of us came to the consideration of health equity. And so it's really been a career-long dedication for her. She's been at the NCI now for 20 years. And it's been a really exciting journey for those of us who have seen Shobha's work in spearheading a number of different initiatives, a number of different funding announcements that have really helped to change the landscape and elevate the discussion around achieving health equity in cancer across the cancer control spectrum, from risk reduction efforts through survivorship and end-of-life care, palliative care, these kinds of questions. And Shobha is both a deep thinker about this, as well as someone who's incredibly passionate about this work. And she really is sort of the tip of the spear at NCI and in many ways at the NIH for leading this work. And so Dr. Srinivasan will be talking about rethinking our biases and methodologies today with a heavy dose of health inequity and equity. So Dr. Srinivasan, thank you for coming to Colorado, and it's been a pleasure.
Thanks, Jamie. Thank you so much. It's very kind of you to invite me to come. So I'm not going to tell you anything today that you haven't heard before. So when I say that, you've all learned, in school you learned your ABCs. what are the intersectionality of biology, social, economic, all those factors? How do they play out? We have this tendency to be reductionist, and I am thinking we need to be not reductionist, but able to look at all these factors simultaneously. And I think I am having sorry. Um, to have a loud voice, all of you can still hear me without it. See? So all these years of yelling at young boys. So anyway, so Cancer Moonshot is an agenda that it was called the Bo Biden agenda, which was to help accelerate the delivery of science to the community and to the bedside. So anyone wants to take a wild guess how many years it takes for science to get from science to people? Any guess? Jamie gave you the answer there, 17 years. Now that means you've lost a few generations, right, in your family in the process of waiting that long? And that too only at high-end centers. You're not going to get it everywhere. So this is a big challenge. So this accelerates it. And one of the big programs within it is on colorectal cancer screening and follow-up care. And that was an implementation science projects. And most of them were in rural areas, two of them in urban areas, if you see. With Kentucky, which Jimmy was part of, right, in the beginning, right? So there's a program in Ohio, Kentucky, North Carolina, rural populations, Chicago, which is urban, Oregon Health Sciences, rural and frontier. So you're hearing the word frontier here now. And in UC San Diego, which has both a rural and urban population. And the idea here is care coordination. So you go through colorectal cancer, as everybody knows, is a highly screenable, avoidable disease. So why is it we have a high mortality? It's a good question to ask, right? So we're finding screening in certain areas to be very low, and practically so we launched on an American Indian program where the screening rate was at like 20% on average in the Southwest. So this allowed us to build a program to build screening and follow-up care. So when people say screening, don't stop there. There's follow-up care. If you're positive, you need the care. So what are the challenges in doing it? How can we know what works. We know there is a fit kit. We know there is Cologuard. We know all this, but how do we get it out into the public? So this has been a process by which we've been doing that. So if you're interested, there is a State of Cancer in Indigenous Communities, November 2nd to 4th in Tucson, Arizona, hosted by the University of Arizona Cancer Center. The rural health agenda, I mentioned it to you earlier. So this is a population that we really didn't have much of a portfolio in. And if I tell people it took us about 7 years to build this program, everybody would be shocked. So, this is like, if you go ask your parents for a $10,000, are they going to just whip out their wallets and give you 10,000 or write you a check? No. You have to come up with a good argument as to why you need the 10,000. And you have to come up with the challenges of doing it, why you need it, and how you're going to use it, and everything, right? Similarly, in the government, we were asking for $10 million. So they needed me to tell them why I was going to do it, why we wanted this money, and whom was it going to help. So we were able to put the program together, got a little workshops going, a meeting going to understand where the gaps were so we could develop a program in this. And we did, they've had now, I think totally we found about to the tune of about $30 million various programs in rural America, which is more than what we had, which was at about 2 million maybe. So there is a meeting, and Jamie and Evelyn Baroya are part of that group, Advancing Rural Cancer Prevention Control in the Next Decade. And it's at the Siteman Cancer Center in St. Louis, Missouri, August 10th to 12th, if you want to come. Seats are limited. Only 100 people are allowed. So you better get your registration going now. So we've had also, leadership changes. So I gave you a deep dive, right? I told you what we're doing in various programs to move the science, to get it to the community, and how we can work on these issues. So we have a new director who joined us in my division, and she came from Oregon, on the Kaiser Permanente in Oregon. And she decided that she wanted to talk to different people about what are ways in which we could move the science even further, given that we have existed for 25 years as a division. So we put out an RFI, which is a request for information, and we gathered all of it. And we got 46 responses, most of them telling us to do more subpopulation work, underserved communities, the medically underserved. So I want to move to another agenda, which is gathering a lot more street cred, if I could say, the telehealth agenda. So 2 years back, most people hadn't even heard of telehealth, right? It was a phone call to your doctor, and your doctor prescribed something to you, and because you couldn't go in. But now the telehealth agenda has really expanded, and the moonshot has kind of picked up on the telehealth agenda on how can these trials really work? And in parallel to that was the whole program now, which has been which is being made into law, is expanding broadband and internet services, of which at least 40 million people will now get these services for free across the US. So I don't know if anyone is from rural America or from frontier areas where you don't get cell service. I know a person who lives on Navajo land and has 3 different phone services, because in one area T-Mobile works, in another area AT&T, and in the fourth area Verizon works, and and then there are some areas where nothing works. So I mean, those kinds of things, if you have to do, you have to be pretty well off to have 3 services working for you simultaneously, which is not a feasible thing. And if you've been wondering, you've been sitting at home and having internet service, there's been like a third of the American population that has not had it at all and had to go somewhere else to get those services. So the agenda is, it's a new initiative, which is to kind of look at lung cancer patients, breast, colon, and lung, and how you can there are different sites that have worked on these issues. It'll be 4 centers that will kind of come together to kind of look at what are the challenges, what are the approaches on various issues that are happening. So there has been some studies that have already been ongoing, and these are on cancer screening and diagnosis. I'll give you all these slides. So if you want to look at it, you can take a look at it later on if you have the time. I always say I'll take slides and never look at it. I have a whole long list on my computer, but I do steal slides from them now and then. Treatment and survivorship is a very big issue. And these are being done by various different organizations. So this is an announcement that's out there that you can respond to, that is looking at applications to use telehealth in cancer-related care across the cancer continuum. Do you know what the cancer continuum is? Okay. Absolutely. Great. So it's the entire, from surveillance to treatment, to prevention, to treatment, to diagnosis, to all of that, to palliative care and end of life. And survivorship for us in our definition includes caregivers. People think survivors are only those who had the cancer, but it's also caregivers who go through that process with the survivors. So this agenda is actually to look at how these interactions happen and how we can improve these interactions. This kind of an agenda would have been unheard of 2 years back. So in some ways, this is the silver lining for COVID, right? And I'm trying to give a positive spin to it, saying here we have a system, we could have done it, but we didn't, we had inertia moving it, and we always threw barrier saying this is not possible, this is not possible. When somebody says something is not possible, challenge it. I mean, don't accept it. It's I heard a very interesting, I know this is a total digression, but I want to share something with you. Washington was trying to fight with the British, and the troops were really suffering dramatically. I'm a history buff. Okay, let me say that. Social history buff much more. So he had no way of kind of boosting up the troops, which had no food and living in terrible cold conditions along the Delaware River. And he just had no way of boosting the troops or getting ammunition or anything to them. But he devised this fantastic plan to cross the Delaware River in the middle of the night on December 25th, knowing that the troops on the other side, who were hired by the British, I'm going to massacre their name, but they were Germans, and they had a big tradition for Christmas Eve to celebrate and party and everything. And he thought if he moved on that day, he could catch them off guard, though they had fantastic ammunition, and have an easy victory. But unknown to him, somebody was watching him. And they told him, or the rest of the troop said, no way. So he only took very few volunteers went with him. So the long story short is he did take them unawares and he won it, which boosted the morale, which ended up in him winning a lot more battles. So what I'm trying to tell you is you have to think of things and saying, when somebody says it's not possible, think of other ways to work it. I know it's a long story, but bear with me. So we have what we call a health disparities portfolio within the division. So and I call it health disparities because it's much more on trying to understand where are the disparities, whether it is age, race, ethnicity, gender, education, income, social class, disability, geographic location, or sexual orientation, any of those issues. So it's just basically from everything from surveillance to social behavioral healthcare delivery, epi, omics research, to longitudinal cohorts. And we have several cohorts that look at all these issues. So it's more explanatory in my mind, and more of a exploratory also, trying to see whether an intervention will work or not work. So we have these definitions which help us guide what we do. And it delineates the process. Basically, health disparities for me, it delineates the process by which different groups face challenges to identify what are the challenges and how you think you can address them so that we achieve the highest level of health. Okay, does that sound good so far? So we categorize them and we say, oh, this is just health disparities. I know this is bean counting, basically, what I call. I say, oh, how many people are we funding? Are we funding everybody? Or do we have knowledge of everything? Then we have this populations which is medically underserved, people who have a hard time getting care for one reason or the other. So it could be based only on, I know you're thinking, age? Why is age a big issue? Why is youth an issue? Youth and age are a very big issue because they have less access to care and less access to resources. Because youth is when you get off your parents' insurance and you get on your own insurance. There's not something that you really have a lot of. And you're just starting off in your career. Think of yourselves. So that's the group that is highly affected also. And actually, what happens to you there affects you for the rest of your life. So it's a very important group. So then we have those that look at, even within this, the disparity issues among the medically underserved. So you look at the rich and the poor, the low income, the middle income, the high income, and so on and so forth. So for me, that is still bean counting if you do that. So that portfolio is growing, the medically underserved. Why is the medically underserved an important agenda? No, this is a health disparities portfolio. I'm sorry. The health disparities portfolio is growing, and it's grown a lot over the last few years. And we love to say this is bean counting and this is wonderful, we're doing this work. But it's really not wonderful. So how do we develop instead an equity lens, right? We did disparity, which just talks about differences. Disparity is difference. So equity is doing the best that you can for the highest level of attainment possible for a population, for all people. So this is something which has been adopted actually in the Healthy People 2010. 2010, yes. But no one ever paid attention to it. So it was three of us who came together and wrote this wonderful definition, and no one paid attention to it. We had it on the website and no one really thought anything of it. And about 15 years back, one of my students and I wrote a paper saying, health equity is the time now. So she called me up the other day. She's a professor in a university, and she says, do you think we should republish the paper saying, is it now, question mark, question mark, question mark, exclamation mark? And maybe then it'll have some kind of people listening to it. It's not easy. If it was easy, we would have all done it, right? It's not easy. So this is what I tell people. Life is political. You're going to fight for things till the day you die. When you die, you'll be fighting for your last breath. So when you're born, you're fighting for your first breath. So your entire life is fighting for something. So don't tell me you fought this. Why am I fighting for it before? Like, it's like going to your parents for money. You have to ask your parents money every time. You have to give them a reason for it. Similarly, everything you have to give a reason for. So it is working towards those avoidable inequalities that you can really work at and change. And it means progress is small in it, but it is feasible. So in underserved communities, whether it be rural or kind of like SGM communities, it is actually, equity means doing more. Doing more means you have to be aware and knowledgeable about the social context in which they live, know their cultural understandings, and do something appropriate. For example, we are all so caught up in doing the perfect research that we don't think about what that research benefit will be. So I'm asking you to think long term. That's all. So this medically underserved population, research just focused on those groups is what is going to open up the area for equity. These groups are looking at, like Jamie has funding and Evelyn has funding to do work in rural America. So it's a deep dive into rural, not a comparison to urban. So when we first did the urban rural agenda, we have a review group in NIH, most of you must have heard. So one of the reviewers said, how will I know this group is doing well if you're not allowing them to compare to urban? I said, yeah, how did you know the urban population was doing well all these years? You didn't compare them to rural. So, it's like, why are you thinking in these boxes? Get out of them. So this kind of research, deep dive into the community with a specific population is what will help us in the long run. Interestingly, we have what I'm trying to show you here is we have the language needed. It's like, how do we translate that language into reality is becoming one of those issues. Do we have the measures? Do we have the ability to do it? The White House executive order was to specifically work with underserved communities, Black, Latino, Indigenous, Native American, Asian American, Pacific Islanders, members of religious minorities, LGBTQ, persons with disabilities, people who live in rural areas, and people in persistent poverty areas. So whether you live in Venice, in St. Mark's Square, or you live off where all these people have beautiful homes off the coast of Florida, we know that we come with a perspective. It's not relativism, but it's perspectivism. And in real estate, we say it's location, location, location. And actually, in social sciences and behavioral sciences, we say it is context. It is the context in which people live. And I was sharing the statistic with Kathy Bradley, and I have to verify it, so don't quote me on it. I think there were 1 million people who live in mobile homes or in cars in America. And that in 10 years increased to 1.5 in 2017 or 19. And now with all the funding going away for rental homes and all that, they expect that number to go up. They don't call themselves homeless, they call themselves nomads. Because they actually move from parking lot to parking lot, from one federal land where they are allowed to stay for 2 weeks to another piece of federal land where they live another 2 weeks, work in places like Amazon and things like that. Now, these are the people who are coming to the door of the cancer center asking for care. They don't have an address, you have no way of reaching them. What are you going to do if you don't understand their context and their realities? So beyond the individual into the community and policy. And it's not that we don't have the tools. This was developed in 2008 in trying to look at from the structural context to the biologic and genetic, and looking at the biological factors, the individual factors, the social and physical context to the fundamental causes. This is also presented in many sciences as an onion in the public health field. And for us, all this contributes to cancer disparities, and it goes across the life course. And they interact with each other. We would love to say it's only biology. No, 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 it's only socioeconomic. It's not only, it's always a layering effect. So, what are our biases and how is it impeding our equity agenda? So when you say underserved, I say, much to the chagrin of the rest of NIH, hitherto not included populations. So people you haven't studied or included in any of your large studies because your models just didn't allow it. Or you included them and they became the noise in your EPI study, right? You so took them out. They were outliers. And outliers just don't have that perfect modeling, right? Just take them out. So these are generally the geographically underserved people, hidden people who live in persistent poverty, and I'll come to what is persistent poverty, and rural areas across America. And what are the population groups? It's just generally sexual gender minorities, racial ethnic subgroups. We tend to put all Hispanics in one group, all Blacks in one group, all whites in one group, and then we say, oh, this is the pattern. And it's just never the pattern. We are off by a lot. So when somebody asked me a question, say, you think we should do it on subpopulation? I said, hello? You're in the time of precision medicine. Why shouldn't you be talking about subpopulations? I think that kept them quiet forever. So you want to talk about genetics and how specific genetic factor you want to take, but at a population level, you don't want to talk about it. Let's get real. So we exclude populations as hard to reach. They've always been there. Just you didn't go there. So that's another problem. We say we didn't include them because of our power calculations, right? We say this study had limited sample size. I remember a person was working with the Haitian community and the review group told her that the sample size was too small. I said, hold it. Let's open up all the borders, get more Haitians, they have them all of them get cancer, and then you want to study them, right? Until then, this is a problem. I'm like, what are you thinking when you make these kinds of statements? I want to know. I really want to know who makes those statements. So, lacks generalizability. This has got to be my pet peeve. Lacks generalizability is what? This is again precision medicine. We're trying to tell you, let's treat you as an individual, see what is your genetic makeup, what is your phenotype, and we will treat you. And you want me to generalize? I mean, let's get our language straight here. So NIH constantly says we should have generalizability to whom and for what? This has got to be the best return on investment. If you have $10,000, wouldn't you like to spend it on 10,000 people rather than 1,000 people? But they're forgetting that old adage, right? You're only as good as your weakest link. If your knee isn't working, can you walk? No. So your weak link is your knee. So if one person in your family can't do something, you can't do it either, right? And it applies to the larger population across America. So you have to be able to bring everybody along with you if you're moving forward. So we practice a lot of exclusion through our intervention design. So we say, oh, it's a challenge recruiting populations over several states. It's a diasporic community. The social contexts are different. And, I can't control for it. So you don't do the study. And you don't include these populations. Like the Hmong population, where they are in Fresno, they're in Denver, and they're in Minnesota. So they're in 3 different places. So you will never study them because they're too diasporic. We say randomization is a challenge in the limited ability to recruit. So here is my biggest line. So if you want large numbers and you want to really randomize, stop funding any studies in the US. Go to China and go to India. We guarantee 1.4 billion people in India and 1.2 billion in China. No problem. You can randomize till your heart's content. So what is the goal here again? So your randomization has been something you hang your hat on, right? Cross-contamination of intervention. These communities are small. They're all very connected. I can't really do a control, which is proper. So we say, oh, it's too much cross-contamination. We won't do this intervention. You cannot really find out what happened really. So what happened to doing pragmatic trials then? I don't know. Never thought of using that design. Why would I do it? So we control the context to maintain the fidelity of our intervention. We are so committed to talking to people on the second week, the fourth week, on the second Wednesday and the fourth Wednesday. Heaven forbid you go away somewhere and I didn't get to talk to you on the second Wednesday and the fourth Wednesday. Now, in Alaska, for example, for the summers, things shut down, meaning everybody goes away and is doing fishing and whaling and everything. So there was an intervention submitted and the person said, it's not possible to do this intervention. So I said, you want to minus this community completely? Tell me what you want me to do. You were like, okay, you suffer with cancer. Nice knowing you. Bye-bye. I said, why don't you write that in your review statement? Let's be honest. Put your money where your mouth is, or put your signature where your mouth is. You have to hold people's feet to the fire. So we don't account for the context in which people live and how the stressors get under our skin. If you go to a rural area and look at the life that people live and the conditions in which they live and what they're exposed to, you will never understand it. Today I was talking with Stacy on my way in, and she was showing me around campus and saying, oh, look at these buildings. I said, it's so interesting, in the work that I do with communities, usually it's with communities who are not very well off. They tell me they would never come to a facility like this because they think you need a credit card to come in. I don't have that. So how am I going to come into this building? She was talking about creating a community where people can come in and feel safe and comfortable and not be that glass building. She's got a challenge on her hands doing that. So what I'm trying to say is we need to think outside the box in this. Or are we going to go out where people are? We need to get out of our lovely ivory towers, right? We don't account for the social needs of people, their limited availability of lack of resources. When you do community research, you understand this. When I was very young and I was working in India, I was trying to get to women. I was doing my PhD work, and it was in the slums of Delhi. And I was trying to get this woman to tell me about her life. She would say, yeah, come at 8 o'clock at night. I'll go at 8 o'clock. She wouldn't be there. And then again, I would come again. I knew the houses that she worked in. I would say, oh, you know what? I missed you yesterday at 8. Can you tell me? She must have tested me at least 5 times. I mean, I had to catch 2 buses and go. And that was not a problem because she had to catch 2 buses to go to work every day. So finally, on the 5th try, she finally gave me an interview, and it lasted till about 11 o'clock at night. And I ended up staying at her house because there was no bus for me to go. And it's a one room. The room wasn't bigger than this. And what it was is I said, how come you never, kind of let me interview you in the beginning? And she told me something which was so good. She said, I don't know whether you were making money off of me or you're really interested in learning about my life. I said, I told you I'm writing my dissertation on this. I won't make any money out of you or anything like that. But she said, I wanted to know whether you were really and truly interested in listening to my story. She wanted to test my commitment. What was wrong with that? Nothing, actually. And, we don't understand how their lives are used and how much it is. But that taught me so much. You cannot expect to go once to a person and say, hey, eat good food. Hey, do this, and expect them tomorrow morning to change. And let me ask you all of this. You were kids. Your parents told you to do XYZ. How many of you did it right away? I'm sure it's 0. If you put up your hand, I'll check with your parents. So it's one of that. So is our bias implicit or explicit? Oh my God, I'm running out of time. Okay, why is it important to compare dissimilar groups? Why is the white group the benchmark? I've never understood this. Who died and made it the rule? And how would you know? And somebody said, how would I know that the Hispanics are doing better than better if I don't have a comparison group to whites? I said, how do you know whites are doing better? In fact, they're doing terribly on many things. But you don't think about comparing them to somebody else, like lung cancer rates in rural America. I don't have to recruit a black population to show that the whites are doing worse. But if it is reversed, I have to. So let's be consistent in our language, right? Journal publications have the same requirements. So we wrote a paper about it, avoiding pro forma. And when we control, what are we controlling for? I'm controlling for color of a skin, which is a social concept on which we base a whole bunch of discriminatory practices. Come on, what has that got to do with what I'm doing? Nothing, but we're controlling for it. And let me tell you, to date, there hasn't been one intervention that has ever been implemented from one community to the other without making a change. You know, it's so funny. I was talking to Russ Glasgow today. I said, Russ, you're the person I should ask. You do implementation science. I said, I'll give you $1,000. Tell me one intervention. He's like, Shobha, you got me. He's like, absolutely. There's not one intervention which we ever take without a change and implement it. So again, generalizing to what? Who are we generalizing to and for what? So it's more important to compare similar groups in similar contexts. So this is like, we have to rethink our approach within subgroups. We have examples. We didn't allow rural comparison to urban. We didn't allow Native American comparison to other groups. Include hitherto excluded populations in databases, like the cancer registries, SGM, the incarcerated. 3% of the American populations have been incarcerated at one point in time or the other. What do we know about them and cancer? Zero. Allow alternate intervention designs, quasi-experimental. Power calculations, when we look at multiple factors, not to take them all into account at the same time, but look at single factors because we can't get the sample size for it. Sustain your work by building partnerships with communities. And I think that's always very difficult. Account for the social context and needs of people, and don't allow the social context to be controlled. Measure social determinants at the individual and societal level. Now, this is another pet peeve of mine. I'm a sociologist. You don't ask me about genetic mutations. You don't ask me about phenotypes or somatic mutations, right? Now, why does NIH think it's okay to go ask a basic scientist about social determinants of health or about race and ethnicity? It should never be the case. There are a whole bunch of sociologists, political scientists, economists who study all this. Why would we talk about income inequality for people who have not been trained in it? So hire teams where you can build your group. I'm not saying don't get knowledge in another area, but believe in team science and do the team science. Just because I have genes doesn't mean I'm a geneticist. Because you live in society doesn't make you a sociologist. So there. So persistent poverty is a deep dive agenda. So somebody told me this, and I'm giving you my example. It's always been defined in the US at a county level. And I said, why can't we define it at the census tract? And they said, it's never been done. And I love that phrase, never been done. Never take that. Never been done means you have to find a way. That's all it is. So what is persistent poverty? It's generational poverty. Poverty over 30 years. You've lived below the federal poverty line for a family of 4, below $27,000 for 30 years. That's the statistic. So it captures generational poverty and the failure of our structures of society. So we developed granular data and took the county, I'm going to go very fast over it, and defined it at the census tract level. And actually, there are 30 million people nearly versus 16 million people who were at the county level. There are 30 million people who live in persistent poverty across the US. So that's the latest agenda that we released as a big centers grant for $10 million a year. And we are hoping, and this is all data on that, and it shows the populations across where you can get at. It actually gets to the persistent poverty at the census tract gets to all 50 states and Puerto Rico. So the data that really what it shows is the granular level, how much poverty there is in the US. So we know that persistent poverty at the county level for avoidable, that is Cancers that are screenable. In persistent poverty areas, it is much higher. Mortality is much higher. And we know there is also intersectionality of persistent versus non-persistent, white versus black. And it is that in persistent areas, it is worse. So there is a need for this kind of work, and that's what the agenda gets at. So the future direction. So I'm talking about operationalizing structural discrimination. How do you do pre-existing measures? How do you develop new measures? And when I talk about discrimination, I'm not only talking about race. I am talking about class, poverty, genderism, all of those issues. And I think we cannot do this reductionist model of tell me one factor that affects health. One factor does not affect health. It is several factors that affect health. Anybody who tells you that is completely wrong. You have to look at how these various factors work together. How do you implement within the healthcare system multiple intervention, implementing multi-level interventions? So when we put out this whole need for addressing structural discrimination, people came in with patient navigation, and I'm like, brilliant. Brilliant, really brilliant. We've had this forever. We've done this. We've shown it's good. It doesn't get to the structures. So what are you doing to get to the structures of society to address this? So how can we measure all these factors? And there are some very, very good measures of it. So we have to do measurement, which is good to practice. So to move to health equity, we have to conceptualize discrimination as a systemic thing. It's not an individual thing. It is a very systemic, embedded in the system. So you have to develop ways to address it at that level. You have to have accountability structures. If they're not including data, as I said, we're challenging, even within our own offices, we challenge each other. We say, oh, you have SEER. Why can't SEER collect this data? SEER is surveillance, epidemiology, and end results. Why are you not collecting this data? And we have to challenge each other in trying to achieve more. Inform policy and program, and of course, policies and practices as we move forward. So thinking strategically and systematically, meaning system-wise, multi-sector, place-based community initiatives, leverage points within sectors. So those are kind of words from much more from economics, probably showing my economics route of looking at where in the system can you kind of have changes which will have effects further down and give you the best outcome that you can. It's not so much money-based as it is kind of maybe personnel-based. How do you transform institutions and disrupt them to have a better systemic way of outlook? So I'm supposed to show you this as something.
Do the survey at the end, please.
Okay, there you go. And that's all I have for you today.
Thank you, Dr. Srinivasan. It's incredible, and I hope that everyone kind of felt as much that you have as much to chew on as I do in terms of challenging some of the ways that I've thought about doing work in this space. I wanted to see if there's anyone who has any questions or comments, and I believe we'll also have some opportunity for the folks who are on Zoom to post questions in the chat, and we will have those presented to Dr. Srinivasan as well. Dr. Wood.
That was excellent. And one of the things that struck me as I was listening is you want us to disregard some of the constructs that we've used in the past. But unfortunately, those are also the constructs by which we're judged by. So when you submit a grant, they will tell you that are your findings generalized? How do you think that we can change this? One thing to tell us is like the grant differently or do the study differently. But we can't do it differently if we're judged the same way.
I would say two things. One is when you sit on review sections, don't use the word generalizability. Make it very clear to everybody in the group that that's not to be used. I think us old fogies have a hard time of kind of giving up our old mentality. The second thing is, I would say, use this as a method to really educate the peer review. I think it is a matter of what language that you use. This is not generalizable because of X, Y, Z. We have, this intervention has to be modified for this, and we are testing these aspects of it. When I get into implementing this at a later point in time, you could probably generalize a little bit more. I think you have to be direct with them. And I think that has worked in a few cases.
Jim, is just a request to repeat the question for those that
Yes, I was going to. So Dr. Wood's question was about, applying some of the feedback that Dr. Srinivasan was mentioning and how that may be discordant from how reviewers are actually reviewing our applications. And so Dr. Srinivasan, was providing some guidance to address that question. I remember the sitting on one of my very first study sections as a very junior faculty member, and having it was a rural focused application, by I believe from at the Appalachian region, and the critique was that the sample was not sufficiently heterogeneous and lacked urban samples, and I did stand up and say, well, do all your urban studies then need to have a rural sample? And I was not warmly received, but we started to change the dialogue after that point, and seeing how ridiculous some of those standards are in terms of the review process. So I think some of our big NCI designated cancer center colleagues at that time in New York City and other places were scratching their heads on that one. But any other comments or questions? Well, Shobha, thank you so much for visiting us in Colorado, and appreciate your time.
Thank you.